Clinical Fellow in Pediatric and Adolescent Endocrinology at Manipal Hospitals, Bangalore. For moderating this case, I welcome Dr. Vaman Khadilkar. He is Consultant Pediatric and Adolescent Endocrinologist at Jahangir Hospital, Pune, and he has been the past President ISPAE. I think he doesn't require any introduction to this crowd or even an international crowd. So we'll move on for case discussion. Dr. Vaman.
Thank you very much, Dr. Shaila and Dr. Divya Lakshmi and ISPAE for giving this platform and this opportunity. I would now like Dr. Aayush to start his case presentation, please.
Is my slides visible?
Yes. Please go ahead.
Yes. Good evening. At onset, I would like to thank Dr. Vaman for accepting the kind invitation to mentor this session. I would also like to thank Dr. Menon and Dr. Raghupati to inspire us, to inspire the young fellows like us to choose pediatric endocrinology. And I would also like to thank the team ISPAE and my mentor, Dr. Shaila Bhattacharya, who has given me this opportunity to present in this platform. So today I will be presenting a case of craniopharyngioma. On the onset, I would like to have a disclaimer that this case is for the endocrine management of a post-op case of craniopharyngioma. Our case also had an unusual association which is still under investigation, and the consent from the parents was taken before presenting in this August gathering. So we have a 12-year, 2-month-old male child who was a post-op case of craniopharyngioma and was referred after 1 month post-surgery for endocrine workup. Just like to discuss the operative history. He presented with a progressive visual disturbances and headache for last 2 years, for which he has been seeing multiple doctors. And one ophthalmologist on his evaluation showed optic disc pallor with bitemporal hemianopia. Seeing this finding, he was referred to a neurosurgeon who did a MRI brain, which revealed a cellular and a supracellular cystic lesion, which had an enhancing lesion and was compressing the surrounding tissue, as seen in this MRI picture. He underwent tumor decompression on 30th of August 2018, and post-op he had diabetes insipidus for 2 days, which was in view of high sodium of 181 milliculant per liter, for which he was given desmopressin for 2 days, and after that on discharge his sodium was normal, that is 143 milliculant per liter, and he was discharged on a very high dose of steroids. He was given oral dexamethasone 2 mg daily, which was equivalent to 40 mg per meter square per day by the neurosurgery team. So post-surgery, 1 month after that, he came to us for endocrine workup. On asking, he had a weight gain of 5 kgs in last 1 month. He was short for parents, though no previous heights were available. And on history, there was no osmotic symptoms. On examination, his height was 130 centimeter, which was below the 3rd centile. The weight was 34.7 kgs, which was at 25th centile. And blood pressure showed a high systolic blood pressure of 140 by 100 mm of mercury. There was right ptosis. On examination of the right eye, he could count the fingers at 2 meter distance, and there was blurring of the vision on the left eye. And deep tendon reflexes showed a delayed relaxation. Also, his SMR was prepubertal. As you can see, as compared to his pre-op investigations, the investigations which were done by us showed a low value of ACTH of 4.28 picogram per ml with low levels of 8 AM cortisol. That was 11.48 nanomole per liter, with low levels of free T4, which was 0.5 nanogram per deciliter, with normal electrolytes and osmolarity. Also, there was done a post-op ophthalmological evaluation, which showed advanced loss of vision in the right eye, and there was temporal hemianopia with some quadrant deficits in the left eye. So the diagnosis was made, which was operated case of craniopharyngioma with central hypocortisolism, central hypothyroidism, and residual visual defects. Based on this, he was shifted from prednisolone to oral hydrocortisone, and the dose was tapered to the physiological dose ultimately to 8.3 milligram per meter square per day. For hypothyroidism, he was started on oral thyroxine at 1 microgram per kg per day, and levetiracetam, which was started post-op, was continued. He was counseled for strict input-output charting, as well as was called for 3-monthly anthropometric and pubertal assessment, and he was also counseled to come back in case of any new onset acute symptoms. 6 weeks post this follow-up, he came with complaint of polyuria, nocturia, polydipsia, which they have noticed for last 10 days. Thinking of diabetes insipidus, we sent the investigation which showed a high sodium of 152 milliequivalent per liter with high serum osmolarity of 310 milliosmol per kg with low urine osmolarity of 101 milliosmol per kg, and the diagnosis of central diabetes insipidus was made. Just to emphasize, there is triphasic ADH response post-surgery. First, post-surgery, the child presents with an acute phase of diabetes insipidus, as seen in our case as well, which is due to rapid secretion of antidiuretic hormone, followed by there will be decreased secretion of antidiuretic hormone post-surgery because of the shock to the neurons, which was seen in our case, followed by normal secretion or increased secretion when there is recovery of the neurons from the edema, and ultimately depletion of the neurons with the antidiuretic hormone, leading to development of permanent diabetes insipidus. Also, we would like to emphasize that starting the glucocorticoids can unmask the underlying diabetes insipidus because it helps in increasing the free water clearance. Post-surgery, repeat MRI brain was done by the neurosurgery team, which showed bilateral optic atrophy with non-visualization of the optic chiasma with residual lesion. He was started on nasal desmopressin at 1 puff per day, which came out to be 10 microgram per day, was counseled to show strict input-output charting to review for any new onset acute symptoms, and was told to continue all the other medications, that is hydrocortisone, thyroxine, and levetiracetam. Also, he underwent radiotherapy for the residual lesion in February of 2019. Then he regularly followed up with us till July of 2019, in which there was non-compliance to desmopressin. As you can see, waxing and varying type of serum sodium as well as serum osmolarity. The compliance was again reinforced, as well as dose was increased to 2 puffs per day. Also, because of low free T4, the thyroxine was increased to 50 microgram per day and ultimately to 75 microgram per day. After July of 2019, there was loss of follow-up for 1 year because of some family conflicts. At 14 years and 1 month, the child was evaluated because he was not growing adequately. His growth velocity was 2 centimeters in last 1 year. The compliance to the hormone replacement therapy was rechecked, and which was adequate. On examination, his height was 138 centimeter, which was minus 2.9 SDS. Weight was 44.7 kg. He was normotensive. Right ptosis has persisted, and he still had prepubertal SMR. The investigations were done. As you can see, there is low value of IGF-1 of 24.5 nanogram per ml with low IGF-BP3 of 1.85 microgram per ml and delayed bone age by nearly 3.5 years at 10.5 years at chronological age of 14 years. There is no need to do growth hormone stimulation test because we know that the post-surgery, because the tumor was decompressed, there will be loss of growth hormone secreting cells, somatotropes. Also, MRI brain was redone to see that there is a stable residual lesion. And he was started on recombinant growth hormone therapy at minimum dose of 0.1 unit per kg per day. And after starting of the growth hormone, 4 months after that, he came to us for follow-up. There was no acute or new onset complaints, and he has grown only by 1.3 centimeter in last 4 months, and corresponding free T4 was low at 0.43 nanogram per deciliter. So we attributed this poor growth velocity to presence of low free T4, and thyroxine was increased to 100 microgram per day. Here I would want to emphasize that growth hormone treatment increases the thyroid hormone requirement, as well as if suboptimal thyroid hormone is present, it will lead to decreased IGF-1, leading to suboptimal growth. Now coming to this unusual presentation, 1 month after the last follow-up, which I have just described, he came with onset of slurred speech, tremors, unsteady gait, with pedal edema for last 3 weeks, for which they have seen a pediatrician outside who has advised to do an MRI brain to rule out any recurrence of tumor, as well as to do an X-ray of the bilateral lower limbs, because on examination there was nodularity of the skin, and then he was referred back to us for further management. On examination, there was persistent of right ptosis, there was presence of tongue fasciculations, resting tremors, slurred speech with unsteady gait. Cerebellar signs were negative. There was bilateral pitting pedal edema with area of induration over both lower limbs, and he still had prepubertal SMR. Because pedal edema was present, thinking that it can be the side effect of growth hormone, it was stopped and IGF-1 values were sent. The neurological symptoms can be because of recurrence of craniopharyngioma, and MRI was done, which ruled out because there was a stable residual lesion, and ultimately on the X-ray, that nodularity came out to be calcinosis cutis, subcutaneous calcifications was there, and it was metastatic because on investigation he has raised phosphate levels, and this cause is still under investigations. So coming to the summary, the child is a 12-year, 2-month-old post-op case of craniopharyngioma who was referred to us for endocrine workup. He was first started on glucocorticoids, followed by thyroxine and desmopressin, and growth hormone was started on minimum dose for poor growth velocity. The calcinosis cutis is an unusual association and is still under investigation. Thank you.
Okay, thank you very much, Dr. Ayush, for that very nice presentation. And Dr. Shaila, your mentor, is also here. So I do want Dr. Shaila also to pitch in if the need be. It's a very interesting case and a peculiar association that you have presented. So we will go to that association a little later. But I had a few comments for the audience and also for a better understanding of this process of craniopharyngioma. And I'm very glad that Dr. Dattani is here, because his special interest is in pituitary genes of pituitary deficiency and craniopharyngioma. So Ayush, couple of things. The triphasic response that you mentioned generally has a not so long duration of non-DI phase. Usually you get DI, then the recovery is pretty fast, and within a week or so the permanent DI actually gets established. So it's a little unusual for this phase to continue that long. It can happen, but it is unusual. Second thing is, you mentioned about the unmasking of DI with cortisol. Again, the little bit of puzzle here is that the child was already on Visolone. Now, it's quite common for the neurosurgery team to actually give either dexamethasone or Visolone. Many neurosurgeons want dexamethasone because it reduces the brain edema rapidly. But at the same time, because dexamethasone has such high glucocorticoid activity, it will lead to a number of adverse effects like hypertension in your case and rapid weight gain. So generally, we would like to actually discontinue dexamethasone at an earlier date, maybe within a week or so, in consultation with the neurosurgery if the patient has improved. That's
Dr. Shaila, would you like to give some comments till Dr. Vaman joins back?
Yeah, can you hear me now?
Yeah.
Yes, sir.
Yes.
Okay, sorry. So Ayush, I was saying that about the radiation, your patient has received radiation. So we are now also going to see the after effects of radiation depending on how many GI were given. As you know very well, the lower radiations are likely to cause different effects, and higher radiations are likely to cause different effects. So you have to also look for things such as precocious puberty if it's a low radiation, and of course, secondary hypothyroidism is already there, but even primary hypothyroidism can develop in your case because of the radiation. And the question that I think is quite germane to this discussion is when to start growth hormone therapy. Now, normally, when we were learning, it was said that at least 2 years, wait for at least 2 years. But I think most experts would now agree that 1 year's wait is enough before you can start growth hormone once you have made sure that there is no recurrence and the patient is stable and there's no hypothyroidism and compliance seemed to be a little bit of an issue in your case. There's a phenomenon of growth without growth hormone. So before starting growth hormone, many of your patients, even with very low IGF-1, do actually grow fairly well. You have to be aware. I would definitely, so I was saying growth without growth hormone. So whenever there is obesity, then your insulin actually drives the growth axis, and these patients do grow quite well without growth hormone. So before considering growth hormone, that's one thing. Your anthropometry is of critical importance, just to be absolutely certain. So I think these are my comments, and I would definitely like to know what happens to that calcinosis cutis, because it's quite unusual, and whether we are seeing an association which we still are puzzled, because your patient had hyperphosphatemia for a short period of time, as far as I understand, the etiology of which could be related to the thirst that the kid was trying to quench, drinking a lot of phosphate containing drinks, I think. Any comments on that, Dr. Shaila, from your side?
Thank you, Dr. Vaman. Actually, it was a puzzle for us when he came for follow-up. Compliance has been a big issue with this because of a lot of family issues. Father being a single father here, and so the follow-up was a problem in this boy. And also, because of the COVID, there was again lag in those periods. And even this time, when he came with this cutaneous calcinosis, he went to the nearby hospital because we are about 15 kilometers from his place. So he came to us only after 1 month. So we had lost that time also. But he did all possible investigations for him to rule out renal, to rule out dermatomyositis. Even we did a biopsy, but we couldn't find. But then digging history again and again, because he was thirsty, he was again irregular with his desmopressin, thyroxine, all these things. And father going for work, he was actually taking every day around 350 ml of Sprite and also about 200 ml of Coke. So this was the only thing which we got an answer for high phosphate.
Yeah. Yes, quite a bit
And
of a puzzle, really.
yes.
Yep.
And in last 10 days, or even when he was admitted in the hospital, we didn't do anything except following up his parameters, and we completely stopped his phosphate-rich drinks. And it started coming down. And actually, luckily, he came for follow-up today evening, and his edema has disappeared. He has lost around 2 kilos. His phosphate level has become normal. He's much
Okay.
better. So
I see. So it perhaps was related to the excessive consumption. Yeah.
Yes.
Wonderful.
But otherwise, I think craniopharyngioma was a bit of a problem, and I'm sure all our pediatric endocrinologists will agree. We all get late referrals from our neurosurgeons, even in the hospital. So we missed these kids. This kid was on a large dose of dexamethasone for 1 month. We couldn't titrate him because he was not referred to us. Only when for follow-up we came, we changed over to hydrocortisone.
Right.
By then he had also had hypothyroidism. So I think we all face this problem
Yeah,
being
true.
in India.
Yes, and I think most people, even parents, they give a lot of importance to the brain tumor and its surgery rather than the hormonal, the hormonal disorder that follows. So there are a couple of questions. Mainly, they are on when to start growth hormone after the diagnosis of craniopharyngioma has been done. And just as we discussed, normally you would wait for a year, make sure that the endocrine axis is stable otherwise, and if the anthropometric criteria are they're sufficient for starting growth hormone, you don't really have to do a GH stimulation test. And then there's another question, is edema an indication to stop growth hormone therapy? And normally the edema that comes with growth hormone therapy would disappear after reducing the dose or stopping for a week, and you can restart either at half dose and slowly push it up to the full dose. So these are the two questions. So I think if there are no other questions, I suppose with Dr. Shaila's permission, we can move ahead. And I would like to thank Dr. Ayush and Dr. Shaila for presenting this wonderful case, because it's something that we face all the time, and nobody is exposed a lot in managing these cases. Every now and then, even in the busiest unit, you would end up seeing about 4 or 5 cases of cranio in a year, but not beyond that. So thank you very much for presenting that case.
Before we close, Dr. Vaman, Dr. Sondram has asked, is edema an indication to stop growth hormone treatment? I think we are always scared. We don't know what would be the side effect. So, in fact, because he came with massive edema, we did stop growth hormone, and we not yet started because it's still improving. But IGF values, even that time before starting, we just did only IGF level, which was markedly reduced. And even yesterday we have done it, it is still very much reduced. We are waiting for a few more weeks till he stabilizes, and we are planning to restart growth hormone for this boy. Thank you.
And I think your anthropometry is so clear that you have to at some stage start the growth hormone again. Yeah, entirely agree. Thank you very much for that comment. Yeah.
Thank you. Thank you, Mama.
Thank you.